So we're going to talk about the neoplasia of the GI tract, part of pathophysiology. I'm not going to talk about the biology of neoplasia. We've already been over it earlier in the year. What I'm going to talk about or focus on will be the different viscera of the GI tract and the different types of neoplasia that occurs along the way. So that's going to be our focus. I'll come back to this slide at the end, so remember to remind me to go back to this at the end. The objectives here, we're going to look at the etiology, pathophysiology, and recognize the signs and symptoms that present as emergent or non-emergent in working up GI possible tumors and appropriate lab and imaging that you need to do, treatment options from good to bad, and a differential diagnosis should be developed. So first of all, methods of detection of neoplasia of the GI tract. We're going to cover this a little bit more detail tomorrow, but there are different levels. One of them is screening for blood. And the two methods really that screen for blood are hemocult and what's called the FIT test, F-I-T test. Hemocult, the other name for hemocult is guaiac, G-U-I-A-C-C. I think that's how you spell it, or AC. Guaiac is what it does is it reacts with the heme in hemoglobin and will turn the little filter paper from white to, or the stool on the filter paper from whitish or brown stool to blue. If you see the blue coloration, that's a positive guaiac or positive hemocult. Hemocults come in cards, the little cards. You know what I'm talking about? You know what I'm talking about because you had it back when we did the mail thing. So there are two samples. So what you do is you give the patient, in the clinic, you're going to do one card. You're going to do a rectal exam, which is one stick, one poke, and you put it on both of the little squares, right? But if you're only sampling the stool in one place, what you should do is, or where the card was, why there are two little squares on the card, is that this is a piece of stool. You're supposed to sample from this end and put it on one little square, and that end and put it on the other little square. You're supposed to sample a stool from two different locations. Now, even if you do that, the sensitivity is as low as about 5% in terms of the sensitivity. So they have colon cancer, you're only picking up 5% of them by testing one time. All right, so that's why the hemocult card, you give them 3 cards and you test 3 different bowel movements in 2 different places, so you get a sample size of 6. Okay? That improves your sensitivity quite a bit. The FIT test, what that does is, well, one of the limitations, a couple of the limitations of the guaiac test is that it's looking for iron. It's essentially looking for iron. I said heme, but it's iron. If you eat animal protein, like a steak, with blood within the steak, there's going to be blood within the steak, it can give you a false positive reading. You can also get false positive readings by eating other things will turn into false positive, a guaiac. So that's one of the issues of a guaiac test is it has false positives that you got to worry about. The FIT test doesn't have the same limitations. It's looking for human hemoglobin. Only human. So you won't cross-contaminate, you don't have to worry about what you eat the day before, what the patient has eaten the day before. it will only be positive if there's human blood in the stool. And you don't have to stick the stool. You don't have to handle the stool. It comes with a brush, a long brush, like that. You just take the brush and you just swipe it along the length of the stool, like that. And you process it like a pregnancy test. It can be done at home, as a matter of fact. And there you go. Okay? It's more sensitive and more specific than a hemocoat, but it's not always used. If you get somebody in a Good Shepherd and you're really concerned about it, then order a fit test from DLO. Okay? And finally, colonoscopy. That's the direct visualization. Now, colonoscopies are so readily done, so easily done. Anoscopy, where you have a little device that's about this long, and it comes with an insert. So it looks like a funnel, sort of. It looks like a funnel. And you put this in the anus, you pull the little middle part out, so you're looking, like a speculum, sort of, but it's a round tube. You're looking at the anus, and you can pull that back to visualize the anal mucosa. I would advise you to never do anoscopy. Always refer, if you suspect a mass, if you put your finger in somebody, if they complain of blood in the stool, you put your finger in there and you feel a mass, refer them to GI for colonoscopy. Don't rely on anoscopy. You can't biopsy through an anoscope. And if you're looking at something you're getting ready to call an internal hemorrhoid, you don't really know if it's an internal hemorrhoid or colon cancer. So do not do anoscopy. Refer them away. The sigmoidoscopies, they used to be rigid sigmoidoscopies, and then later on they came out to be flexible, but now you don't do flexibles. If you're going to stick a fiber optic instrument up somebody's hiney, do a colonoscopy and get the entire colon, not just the sigmoid portion. Although most colon cancers arise in the sigmoid portion. Okay? Now, the other thing in terms of methods of detection is the symptoms that the patient presents with. Pain. And you don't have pain. Remember that pain of the GI tract is only going to be caused by, in terms of your level of consciousness, either what two functions? Ischemia or distension. So if you have a mass lesion of the liver, the only thing that's going to cause pain is if that mass is distending the capsule of the organ. Distending the capsule of the organ, or it's pushing on something else, or it becomes ischemic. Presenting with symptoms, achalasia is they can't swallow. Dysphagia is difficulty swallowing. We have several patients over in Good Shepherd now that have dysphagia or achalasia. You make sure that they have had an EGD or somebody's taken a direct look at the esophagus if those are the presenting complaints. Painless jaundice is always cancer of the head of the pancreas until proven otherwise. I think I probably mentioned that to you back in anatomy. Due to obstruction of the biliary tree. You're always concerned about any patient that has an unexplained weight loss. Not I've been dieting, or I'm hyperthyroid, or something like that. Unexplained weight loss, you better start looking for tumor. Changing the character of the stool. Color is one. If a cancer in the head of the pancreas obstructs the bile duct, what color is the stool?
White.
Light. It's tan colored, right? If it contains blood from a bleeding tumor of the esophagus, or more like the duodenum or the stomach, that blood is going to be digested somewhat, and it's going to appear in stool, not as bright red blood, but as a darkening of the stool from the iron. That's why you tell people when they take iron, be aware that your stools are going to turn black. That's melena. So melena is a high GI bleed. Now, it doesn't always have to be from cancer, obviously, but that's great. Versus hematochezia, which is a little bit to your right. Hematochezia is the presence of bright red blood associated with the stool. Okay? Two different things. Obviously, obstruction, and the other things about the stool, though, are the diameter of the stool. You ask the patient, is the diameter of the stool changed? If there is an apple core, what's called an apple core lesion of the colon, so if you've got colon cancer, again, it's in the sigmoid, that's where it's most likely to be, right? So you're looking at the lumen of the lumen of the colon. This thing is going to constrict, so the stool, instead of being nice, chunky like that, is going to be more ribbon-like. So that's what you're looking for. That's called an apple core lesion. It looks like, you know, you're eating around an apple. Okay? And then frequency. Stool frequency is so these are the things you always ask if you're dealing with a GI complaint. Incidental detection, unfortunately, most of the time, things are found because you were looking for something else, and usually the outcome is not good. So we'll go over that later on. Modalities for detection. KUB, kidney urinary bladder, is the standard plain film view of the GI tract. It's taken from the kidney, level of the kidney, so it's got the CVH, you get the bottom of the lung field to the urinary bladder, so you're going to get pelvis. You do it upright and a supine. I think we talked about this before, right? Have we talked about this before? So upright and supine. You're going to have a lecture from a radiologist here, I think this week, on abdominal films, but KUBs are the what you can do in the office, right? I have a friend of mine who's a family medicine doc will never do a KUB. Never, ever, ever do a KUB. Every abdominal complaint that comes in, it's a CT of the abdomen. Because of the incidence of liability with KUB. You're missing something on a KUB. He gets a CT on everybody with an abdominal complaint. Not with everybody with an abdominal complaint, but if he would have gotten a KUB, he would get a CT of the abdomen, and that's with and without contrast. And there are two forms of contrast with CTs of the abdomen. One is they inject contrast material into the vascular space, or to the vasculature, that will highlight the arteries and veins of the GI tract. The other is you have them drink contrast material that lines the inside of the gut. So it's a double contrast study, both vascular and intra-GI tract, whatever you would call that. Okay? Ultrasound, or the other commonly used modality, ultrasound. When you say, you have to be kind of careful when you're ordering an ultrasound. You don't order an ultrasound of the abdomen, because they're not going to do it. You have to be specific on what you want ordered. You want an ultrasound of the biliary tree. Do you want an ultrasound of the liver, pancreas, and biliary tree? Do you want an ultrasound of the kidneys, ureters, urinary bladder? So you have to be, when you order an ultrasound, be specific in what you're looking for, okay? What are gone these days are upper GIs and lower GIs, where you drink barium and that's all you do, or they give you an enema with barium up back. You know what an enema is, right? Yeah. Okay, you look like. So they pump a gallon of this stuff up your hiney, and then you poop it out, or you hold it in, and they shoot the X-ray, and then you poop it out, and then where it was, it lines the, so do a Google, if you're looking at me, Caitlin, like, what the hell is he talking about? Do a Google images of a barium enema. You'll see that where they put it in, it's a solid outline of the lumen of the GI tract. Doesn't tell you anything about the organ itself. It's just the lumen you're looking at. And then they poop it out, and where they poop it out, you'll see that it gives you a sort of a shadow of the lumen. So there are two different things. Samantha, I can't get used to that haircut. Just want to let you know. Okay? The other thing is you don't see an MRI up there. MRIs and MRAs are not done when you're talking about the if you find something bad, PET scan is commonly used in the workup of GI neoplasia to look for spread. You guys know what a PET scan is? Anybody not know what a PET scan is? Raise your hand. Okay, good. Bone scans are also done at the same time as PET, or along with PET scans, not at the same time, but along with PET scans to look for metastasis to the bone. If there's, if you're dealing with neoplasia of the GI tract, in management of that, taking your case to a tumor board is probably gives you the best chance for survival in terms of how to treat these malignancies. And most of these are malignancies that we're going to be talking about. So the origin of neoplasia comes from basically two different places. There are some neoplasia that come from bizarre places like lymphoid. We're not going to really deal with it. We're going to talk about the two primary and then a little bit of a tertiary, but the two primary places are either the tumor is going to be squamous in origin or it's going to be adenomatous or glandular. So if you look on that top part up there, this is non-keratinized stratified squamous epithelium, like the inside of your mouth. The difference between that and the skin is when you put your finger in here, it's not keratinized like this. So you see live cells all the way to the top. In your skin, you have layers and layers of nothing but bags of keratin that are without any nucleus. They're just bags of keratin. These things are live cells all the way to the top. So inside your nose, inside your oropharynx, down to about the hypopharynx here, inside your anus, up about 1.5 inches. That's where you're going to find squamous malignancies. The rest of the place is essentially glandular in origin. Now there's some exceptions that we're going to talk about, but most of them are glandular. So if you look at the epithelium of the lining of the GI tract, you'll see these cells right here. These are ciliated cells. They got little cilia on the top. They just sit there and beat and propel mucus and stuff along the way. That's all they do. But one prominent cell type here is the goblet cell or mucus secreting cell. You see these little cells right here? These are the glandular cells of the GI tract. And they're everywhere. They start at the base, bottom third of your esophagus, and you'll find them all the way down to your rectum, okay? On about 1.5 inches from the bottom. Amy.
Those are the goblet cells?
Well, you just call them mucus-secreting cells.
Okay.
Yeah, mucus-secreting cells. You can see the fatty mucus inside these things. They look like little goblets. Okay? All right, treatment options. Treatment options are one of the things when you find a mass, you're going to have to sample it. Biopsy, you've got to biopsy everything from the mouth all the way down to the anus. Most of these biopsies are done pretty easily, either directly in the mouth or endoscopically. And you can just about get to anywhere. If it's way down in the small bowel, you may, or in the jejunum or proximal ileum, you're probably going to have to do it laparoscopically. So it'll be an OR type thing. Once you get the biopsy, if it's a malignancy, it's staged. And you know about the P&M staging system that's used. It's used throughout the GI tract here. It's used throughout the survival rate is determined by the staging throughout the GI tract. The term debulking, I don't know if you've heard that term before. Debulking is if we find a tumor, if a tumor is found and we're going to go and resect this thing. But the problem is on CT, it's too big. It's wrapped around your inferior vena cava or it's wrapped around something else. It's too big. We need to debulk it. So we're going to start you on chemo and we're going to start you on radiation therapy to shrink this tumor to get it to a size where we feel we can go in and remove it, or remove at least most of it. This happens a lot in oral cancers where a lot of times they'll go undetected and they'll get pretty large and they'll invade different parts of the neck. And what you can do is debulk the tumor and go in there later on and remove the core of the tumor wherever it may happen to be. So you'll hear the expression, we're not going to do surgery now, we're going to treat you, we're going to try to debulk the tumor before going in there. That's usually not a good sign. Chemotherapy and radiation therapy, alone or in combination, are going to be used in different parts of the GI tract. Radiation therapy is used in oral cancers. Chemotherapy is used in most of the rest of the GI tract. Chemotherapy is also used in oral cancers that have metastasized. You can't go radiating the entire body. So pancreatic cancer, gastric cancer, those types of colon cancer, those things are usually confined to chemotherapy. Right. The radiation is one of the primary modalities for treating oral cancer. Surgery, of course, and palliative care. You guys know what palliative care is now. Palliative care is unfortunately, because the GI tract has so much room to move, a lot of times by the time things are found, they've already advanced to a significant stage where you're trying to make the patient comfortable. Now, interesting, there are some targeted therapies that are that are out there now that are used, have a molecular approach to them. They're either biologic compounds that are specific to things like epidermal growth factor, or they target a protein that prevents angiogenesis. If you've got a tumor, remember one of the things that is required for tumor survival is that they're able to generate or cause angiogenesis within the tumor. Otherwise, they become necrotic. So some of the newer drugs out there, they're designed to stop angiogenesis and let the tumor die from its own size, essentially. There's a mitogen-activated protein kinase drug out there. I have never prescribed these drugs, obviously, but you're going to encounter people that are on them. Unfortunately, most of these drugs don't, well, you'll see later on, they come at a very high cost and they have a limited effect. So you have to talk with your patients, especially if you go to work in the Stevenson Cancer Center. I mean, there are a ton of PAs that work over there. If you're trying to talk to a patient, I can put you on this drug. It'll probably bankrupt your family, but you might get 3 more months of life out of it. So what do you want to do? Cancer of the oral cavity. Let's start here. We're going to start in the oral cavity, kind of work our way to the backside. You've got to remember the precancerous lesions, leukoplakia and erythroplakia. These things right here, leukoplakia, it looks like cottage cheese that's stuck to the side of the tongue or underneath the tongue. You could take it looks like you could take a tongue blade and just wipe it off. That's the difference between a yeast infection and leukoplakia. A yeast infection, you can. Leukoplakia, you can't. I've seen a lot of this in Good Shepherd, so make sure when you are seeing your Good Shepherd patients, you get them to take the tongue and touch the top of their mouth, because that's where this crap grows. It's underneath, and obviously the lateral tongue is a big place for it. As you see here with this case of erythroplakia. Erythroplakia is a more ominous condition, more likely to lead to true malignancy. Now, 90% of the oral cancers are squamous. That's because 90% of your mouth is squamous. It doesn't become non-squamous until you get way down into the, really the lower part of the esophagus. So from the bottom third of the esophagus all the way up, it's mostly squamous. There are some odd ducts, like salivary tumors, that are going to be adenomatous, obviously, and then lymphoid and melanoma, which is, there they are, okay? Neck nodes are the place where these things metastasize. That's obvious. There are quite a few cases of this that occur every year. I've known 2 cases and friends of mine over the past 5 years that my next door neighbor wound up with squamous cell CA in the mouth or the oropharynx, and a guy I go hunting with did. He was in his 30s. The other guy was probably in his early 50s. So it's a nasty little tumor. It is a malignancy. It is a malignancy. High malignant potential. You look at the survival rate here. 10 years ago, it was about, what, 50% here? 50%? 10 years ago, about 50%. Well, now the survival rate has gone all the way up to 57%. That's not good. That's not good for a 5-year survival. You're telling a 32-year-old guy he's got a 5-year survival of 57%. That's not good. Well, the jump from 50 to 57 is caused by the prevalence these days of most squamous cell oral cancers are due to HPV. Look at the survival rate there is 75%. If you look at the 5-year survival rate, if it's not HPV associated, it's still the same as it was 10 years ago. There's been no improvement in not endemic, but intrinsic, non-HPV induced squamous cell CA, not 1 percentage point of survivability in the past 10 years for this cancer. Once you take away HPV. That's pretty impressive right there, in a bad way. Now, what's impressive in a good way is that you and your offspring need to be vaccinated for HPV because of save yourself from some oral cancers here, okay? Now, treatment options with squamous cell, after you get the biopsy, after the CT is done to know the extent of the lesion, and most of the time, by the time you find it, it's already invaded too much to do a whole lot with. You gotta get a PET scan to determine exactly where it is, and then you're gonna have some type of surgery, hopefully. Hopefully, you're gonna be put on chemotherapy. You're gonna undergo radiation therapy. Targeted radiation therapy. Now, the problem with radiation therapy in the oral cavity is that you have a lot of fast, high metabolic rate cells. And that radiation is going to target them just as much as it's going to target the cancer. So one of the things that happens is when you have oral cancer, they're going to put a PEG tube in. The PEG tube is a gastric feeding tube. Sticks out the side of your abdomen, right? Because that's how you're going to eat for about a year, through a PEG tube. It's also going to, extract your molars. Two from the top, 2 from the bottom on each side. Take out your molars because the radiation is going to burn the gingiva and they would fall out anyway. So to avoid the risk of abscesses, they just prophylactically, before you start radiation therapy, you'll have your molars removed. The common complaint of people with undergoing treatment here, the two common complaints is xerostomia, not stomia. It fries your salivary glands, so you have dry mouth. And the other thing is that it fries your taste buds, and you can't taste. And those are the two most irritating things that will last for 1 to 2 years after the radiation therapy. It takes a long time for it to resolve, if it ever does. And most of the time it will, but you won't get it all back. But that sensation, you need to warn patients, this is going to happen. Now there's a drug you can use to pre-treat the person before they get the radiation therapy. What that does is it shuts down the metabolism of the taste buds and salivary glands, shuts it down so that they're not impacted by the radiation. It preserves them just by shutting down their metabolism. The other thing that they do to try to preserve tissue is they cool. What they'll do is they've got a mask they put on their neck or their lower face and neck that just lowers the temperature of this area quite a bit. It's painful. And it takes a while to do this. Then they take it off and do the radiation therapy. So those types of treatments help preserve tissue, but they always lose taste and salivation to a noticeable degree. Have you had that before? You guys had that before? Okay. All right. If there's bad stuff I'm going over, just let me know. Okay. If you look at the esophagus, move on down to the esophagus here. Esophageal cancer, if it's in, like I said, if it's in the upper 2/3, it's squamous. Bottom 1/3, it's adenomatous. Interesting, there's a issue here with the U.S. Most esophageal cancer involves the lower 1/3. And there are probably some reasons for that. If you look at the risk factors for that, what impacts the lower esophagus? Alcoholism with Barrett's esophagus, smoking, obesity, reflux. Why do they not have reflux in India? They don't freaking live long enough, right? They don't eat the same crap we do. We have reflux, they don't, okay? So our risk factors tend us more towards adeno versus squamous CA, okay? The diagnosis by biopsy, once you, oh, by the way, back up, let me back up. If somebody complains, keeps coming in, the same person keeps coming in, bouncing back to your with a sore throat, it's just not getting better. Feels like there's a fish bone caught in the back of my throat. Be quick to pull the trigger on a CT. Don't sit there and jack around with these people for 6 months trying to treat them with, Zithromax, and I'm going to give you a little mouthwash, gargles. No, if somebody bounces back once or twice from a sore throat that's not getting better, they go for a CT. Okay? Don't mess around with this and miss it. Okay, so esophageal cancer. Same thing was esophageal cancer. Somebody keeps coming in complaining of esophageal complaints. The change in heartburn, an increased frequency, more severe, vomiting blood especially, achalasia, dysphagia, anything like that. That needs to be worked up. Don't mess around, especially if they're an alcoholic. First person that I ever knew that died of cancer was Charlie King. I knew I was going to give this lecture. I got thinking about Charlie King today. Charlie was a merchant seaman. You know what a merchant seaman is? You know, the tankers out there, the container ships, the people that work on those ships are called merchant seamen. It's like a C-S-E-A, man. I know what you're thinking, so that's why I had to spell it out for you. Charlie was an alcoholic. When he got back in port, he was always drunk. And he smoked non-filtered Camel cigarettes. You remember that they used to, I don't know if they still do, they made them without a filter. And he died, I remember him getting esophageal cancer and dying when I was about 14, 15 years old. That was the first person I ever knew died of cancer. So he had two of the risk factors, alcohol and smoking right there. Okay. Survival rate for esophageal cancer is horrible. It's just not good. Okay. One of the things in the playbook for treating it is not removal of the esophagus. You have to work around that. Okay. You can see the survival rate as it moves away from the esophagus gets down into the single digits. And that's kind of a general rule of thumb. When we go all the way through the GI tract, if it's gone outside of the capsule of the organ, then you're looking at, most of the time, single-digit survival rate for 5 years, if they even give you a 5-year in some of them. Okay? Any questions about this? Here are the signs and symptoms of esophageal cancer, and basically it's freaking anything. Anything involving swallowing. And be, again, quick to pull the trigger. And the problem with all these GI tract tumors is you're not going to feel them most of the time. You're not going to feel them. You're going to have to use your clinical judgment. Is this heartburn in that merchant semen? Is that heartburn GERD, PUD, esophageal cancer, gastric cancer, duodenal cancer? So you just have to be thorough in how you work these up and smart in how you work them up. If they don't respond to some type of antacid, a PPI, or some type of coating antacid, you better be quick to pull the trigger on this. I don't mean get a CT on everybody that walks in the door, but you need to be smart on this. Tylosis, by the way, is a goofy condition where it's, if you do Google images, it's like a callus type stuff on their hands and feet. It's a genetic condition. It's just a risk factor for esophageal cancer. You don't need to worry about that really. Okay. Any questions about any of that? Here's esophageal cancer here. You see the sort of the normalish mucosa. That's not even normal over here. But that whitish stuff, invasive stuff there, that's esophageal cancer. And judging by the extent of it, it's going to be not a good outcome for that patient. Okay. Gastric cancers, these are bad. Stomach cancers are bad. They come in different types here. There are a lot of different types. Adeno is by far the most common. Adenocarcinoma by far the most common. But you do have things like lymphatic, and then, by the way, they're usually a lymphatic type tumor with all of the viscera. So, but then you get lyomas. So a lyoma is a tumor, a benign tumor of the smooth muscle of the stomach. These things are very rare. The squamous cell, exceptionally rare because you don't find many squamous cells in the area. And then carcinoid is a tumor we're going to talk about here in just a second. Carcinoid is a benign type tumor that we're going to talk about in just a second. So just keep that in your playbook. Let's focus on adenocarcinoma. 5-year survival is low. It's down in the 20s, so it's not very good. Gastric cancer is not prevalent in the United States. It is very prevalent though in Asia. The Asians, you know, the thing that they always show you, and I showed you actually, is that if you've got an Asian population here, the Asians are notorious for having low rates of colon cancer. But then they move to San Francisco or the US somewhere, and they adopt our dietary patterns, and then over time, they develop our higher incidence of colon cancer. The problem is, where they benefit by having low rates of colon cancer, they have a huge rate of gastric cancer. I'd much rather have colon cancer than gastric cancer. I really wouldn't want to have either one of them, but this is not fun. I don't know why that is, it just is. Okay. If it arises near the distal stomach, it's much better in terms of its prognosis than if it arises in the cardiac. Okay? Treatment here, you can get after the stomach with removal, partial removal, and then, of course, chemo and radiation therapy are given with gastric cancer. Now, carcinoid, let me, before we go further into gastric cancer, let me just talk about carcinoid tumors here just a second. They're an unusual thing here. Most of the time they occur in the GI tract. They're mostly benign, as I said. What these things are, they're part of the neuroendocrine system. They produce hormones, and one of the predominant hormones they produce is serotonin. So as these things are growing, they produce sort of a serotonin syndrome, which is tachycardia, high blood pressure, facial flushing, peripheral vasodilation, all sorts of things like that. They have characteristic features, and so if you see somebody with these characteristic features, you call it carcinoid syndrome. And that's what this next slide is showing, carcinoid syndrome, where they have flushing, redness of the face here. Most of the time it's due to serotonin, kinins, and other types of molecules are also released by these tumors. The problem with these tumors is if they're, well, it's not really a problem, it's actually a benefit. Most of these tumors arise in the GI tract, and most of them in the ileum. I may say that somewhere up there, but in the ileum is where most of them arise. Where does the blood from the ileum go? Where does the venous blood from the ileum go? Where, Mariah?
To the inferior ventricle.
Eventually.
Goes.
It goes to what? Superior mesenteric. Where does that go? To what? Eventually, where? To the liver. It's portal. Everything from the GI tract is portal. If you have a carcinoid tumor that develops in the GI tract, that's good because it's going to be metabolized, the product is going to be metabolized in the liver, and you're not going to have the effect. The bad thing about carcinoid tumors is that they don't arise in the GI tract, where you don't have the liver that first passed through the liver to detoxify it. And like I say here, if in the lungs, like tough noogies, okay? All right, going back to stomach cancer here. You can look at the survival rate for stomach cancer. 1A is not so bad, but then you get down here, stage 4, in other words, you've got mets to a distant site. Again, you're back down into the single digits. Okay? Any questions about that? Risk factors for stomach cancer. There are a lot. One of the things I want to focus your attention on is things like atrophic gastritis. Atrophic gastritis is an absence of parietal cells in the stomach. Atrophic gastritis is an absence of parietal cells in the stomach. What do parietal cells produce? HCl and what? Not histamine. Intrinsic factor. What does intrinsic factor do? It's related to that right there. So if you don't know what intrinsic factor is and what pernicious anemia is, you need to go look it up. Those things are related to to atrophic gastritis, which hopefully, is that on the list there, by the way? Is atrophic gastritis, okay. So these are related. The other thing about this is that, you know, back when we were living in the Appalachian Mountains, and we would kill a bear or a hog, and we would smoke that hog, and all of those nitrates and nitrites and stuff, and the smoke got in, that's how we cured the meat. People who eat a high intake, have a high intake of smoked meats, have a higher incidence of gastric cancer. Where it says smoke there, they're not talking about cigarette smoke, they're talking about like smoked meats. So because we eat less smoked meats now than we used to, the rates of gastric cancer in the U.S. are actually going down. Okay? The symptoms are, well, everything. We'll talk about that in just a second. By the way, anybody here like beef jerky? Beef jerky? Might as well put a gun to your head. I'm thinking about the billboard. Remember the billboard we talked about? Was that an anatomy that went by the billboard? The meat company that had the hot dogs, yeah, the hot dogs. Okay. Let me go over this and then we'll take a break. All right, so right here, palpable enlarged stomach with secession splash. The secession splash, I'm not even going to talk about this when we do exam of the abdomen, but let me tell you what it is. Andrew, could you come up here? If you have a fluid level in your, somewhere in your GI tract, lie down for me here. Yeah, get this one. What a succussion splash is if I press down like this, what you do is you're pressing down on the fluid, and then how, you know, you press it down, and it comes back up and hits the, you know, like you do a smack of thing of water, how it goes down and then comes back up. That's the succussion splash. So that's what you're feeling. So thanks, sir. There you go. Excellent, excellent. All right. The next thing here, enlarged lymph nodes such as Virchow nodes. Virchow or Virchow, I don't know how you pronounce it, is an enlarged supraclavicular lymph node on the left side. It's the left side, not the right side. Why is it the left side?
Thoracic
Right, because that's where the thoracic duct goes. There's also called an Irish node where they have lymphadenopathy here in the anterior part of the axilla. Okay, there's another node that you may see. This is called a Sister Mary Joseph node, and what this is it's a lymphatic tissue that develops at the umbilicus. Why it develops there, no one knows, but you can see that this is not a normal belly button. You can see on this CT that there's something there at the belly button. It's a symptom like Virchow's node that there is an intra-abdominal neoplasm. Where, you don't know, but that it's there. Sister Mary Joseph, turn of the 19th century, I believe, was a surgical assistant for some surgeon and just happened to notice that everybody that had one of these belly button deals had a malignancy of the GI tract. And she was the one that observed it, told it to the surgeon. The surgeon published a paper on it, thinking he was going to get all the glory for discovering this. But in fact, what happened is they recognized he was full of shit. She was the one that got off, should get off, and she got the name. Huh. So anyway, any questions? Notice that H. pylori is a risk factor for gastric cancer. Amy?
The Irish node, is it just in the left axilla or both?
Yes, left.
Okay.
Left. Okay. Why don't you take a break and then we'll come back and we'll do the bottom part of it.